Yes, ma'am, I will do.
प्लीज एक बार रीनेम कर दो.
Ma'am, we are on live on YouTube and recording starting. Yes, ma'am, you can start the webinar. I will do these changes.
A very good evening. Ma'am, shall I start?
Yeah, yes, please, Manisha.
Okay. Good evening, everyone. Welcome to the 20th episode of the CCC series. Today, I take immense pleasure in inviting Dr. Anju Soni ma'am. She is the head of the Department of Obs and Gynae in Soni Group of Hospitals, Jaipur. Ma'am actually needs no introduction, but I still would like to tell that ma'am is the current sitting president of IMS, governing council member of ICOG, and she's been the Secretary General of IMS in 2022 and 23 as well. So I welcome you, ma'am. Now I hand over the baton to Dr. Kavita, Dr. Shruti, so that she can introduce the chairpersons and start the session, please, Shruti.
Can I take over for a minute in between?
Yes.
Yeah, thank you for your introduction, dear. I would like to welcome each and everyone today. Good afternoon on the 20th episode of our CCC webinar series. It's my pleasure to have all of you here today. Today, we are honored to have with us none other than Dr. Leela Digmurti, President of ICCP for the term 2021 to 2024, as our esteemed moderator. She will shed light on a very critical issue of cervical intraepithelial neoplasia, difficulty in decision. The cervical intraepithelial neoplasia, commonly referred to as CIN, involves abnormal cells growth on the cervix surface, and the condition is categorized into 3 grades: CIN 1, 2, and 3, and with CIN 3 being the most severe, has the potential to progress into cervical cancer, and if left untreated, highlighting the importance of regular screening and appropriate management. Dr. Digmurti's insights will be invaluable in understanding the complexities and the challenges involved in diagnosing and treating CIN. Her expertise will guide us through the nuances of decision-making in clinical practice, helping us provide best possible care for our patients. We are also privileged to have with us distinguished panel of experts joining with us on this webinar: Dr. Anjana Chauhan, Dr. Bharti Abhyankar, Dr. Bhagyalakshmi Nayak, Dr. Jeena Baburaj, Dr. Jyoti Meena, Professor Meeta Gupta, Dr. Reena Srivastava, and Yashundra Gaur. Their collective knowledge and experience will undoubtedly enrich our decisions, provide diverse perspectives on this vital topic. Our dedicated coordinators for this event are Dr. Kanchan Prasad, Dr. Manisha, and Dr. Shruti. Their hard work and commitment has been instrumental in organizing the webinar, and we are all grateful for their efforts. As we delve into today's topic, I encourage all of you to actively participate and ask questions, share your thoughts. Your engagement is crucial for fruitful discussion and the advancement of our collective understanding. I thank once again all of you for joining us today. Let's make this webinar a productive and insightful experience. Over to you, dear.
Yeah. Good afternoon, everybody. I'm Dr. Shruti here. So it is wonderful to be here on the CCC series every time on every Wednesdays. So now I'm here to introduce our moderator and the esteemed panelist. So starting with Dr. Leela Digubharti.
Madam has already introduced me, so you can start my introduction.
Yeah, definitely, ma'am. I'll just tell everybody briefly that she's a renowned gynec oncologist at St. Teresa Hospital, Hyderabad. She's the present Indian Society of Colposcopy and Cervical Pathology president. She's been the president from 2021 to 2024. She's definitely a certified colposcopy trainer, and she's been training at several places, and she's also as a speaker in several national and international invited speaker. And she also started the program of Screen the Mother and Vaccinate the Child for cervical cancer elimination. That's a very good initiative which she had started. So, and she has been a DNB teacher and examiner for over a decade for now. So we are really privileged to have you here in our webinar, ma'am. We welcome you. And then coming to our panelists now. So we have Dr. Anjana Chauhan. She's a consultant gynae cancer surgeon at Radiance Hospital, Ahmedabad, Gujarat. And then we have Dr. Bharati Abhyankar. She's also a recognized Foxy recognized colposcopy trainer. She is the present vice president of EMOX from 2024 to 2026. And then we have Dr. Bhagyalakshmi Nayak. She's the professor HOD Department of Gynec Oncology in Cuttack. And she's the chairperson of Onco Committee. She was the chairperson of Onco Committee in Foxy from 18 to 20. And then we have Dr. Jeena Baburaj. Definitely, I am a little more connected to her because I'm in the same state as she is in Kerala. So she's a consultant in Calicut district of Kerala. Instead of reading her whole lot of achievements, she is a very, very active in all the cervical cancer related awareness and training programs. She conducts abundant training programs, even online, offline, and everything. It's a privilege to have her here. And then we have Dr. Jyoti Meena. She's an additional professor in Department of Obs Gynae in AIIMS, New Delhi. She's also, interested in preventive gynec oncology, and she has publications of more than 50 papers, and she has been authored in 4 chapters in a book. And then we have Dr. Meeta Gupta. She is the Dean of Academic Department and Professor and HOD of Department of Obs Gynae in AIIMS, Vijaypur, JK, Jammu and Kashmir. And then we have Dr. Yashodhara Gaur. She is again a professor in GR Medical College, Gwalior. She's been in the medical teaching profession since 25 years. And she's the president of MP State Chapter of Association of Gynec Onco. She had been like 20 to 23. So we welcome all the panelists to our webinar, hoping to have a very fruitful discussion with such qualified and experienced faculty in today's webinar. So the stage is all yours. We're waiting to hear from all of you. Thank you.
Yeah, thank you very much, Dr. Shruti, for your wonderful introduction of the moderator as well as the panel members. Can I start now?
Yes, sure, ma'am.
Yeah, okay. So let me share the screen.
Yes, ma'am.
Yeah. Is it visible now? I'll make it full screen.
Yeah, please make it full screen.
Yeah. Yeah. Can I start now?
Yes, sure, ma'am.
Yeah. So once again, my sincere thanks to Dr. Anju Soni, convener of this CCC program, and this is the Wisdom Series webinar of 20. Thank you very much for inviting me to moderate this session on cervical intraepithelial neoplasia, difficulty in decision. So once this title is given, I thought I need to put some scenarios. I mean, these are real cases. These are not anything just made kind of a thing. So the case scenarios, I thought we can have a wonderful discussion about all these difficulties in decision making. And I know I have a wonderful panel with me. They're all very well experienced gynae oncologists, are holding a big post as HODs and a lot of commitment towards gynecologic oncology. So definitely I expect a lot of inputs about the difficult situations, and that would be a feast to the delegates who have joined. And I sincerely welcome all the delegates who have probably must have finished their outpatient faster and must have joined for this webinar. So without much waste, let us go into the discussion part of our webinar. So before actually we start, I just thought very briefly, anyway, Anju Soni madam has given the importance of the cervical cancer prevention. So very brief introduction from my end also. So we know as a primary prevention about HPV vaccination, and as a secondary prevention, we all do screening of women, eligible women. So either by VIA, HPV or cytology. Once we find any abnormalities in any of the screening tests, either we use screen and treat approach or screen triage and treat approach. So for the screen triage treat, all of us use colposcopy, and then we have a variety of treatment modalities, the simpler treatment modalities in the form of ablation or excision without considering straight away hysterectomy. So this is the way to, or I can call it as a road to prevent cervical cancer or reaching the cervical cancer elimination targets. And I think because it's a FOXY session, and I know most of you are familiar with the FOXY recent updates on cervical cancer prevention and management of cervical cancer. So this is just quick run through. When we do a primary screening, VIA or HPV DNA, the basic screen and treat approach is useful for anybody in general population. That means when they are not immunocompromised, you can do a primary screening with VIA or HPV DNA. If they are negative, definitely you call them back either after 3 years for VIA or after 5 to 10 years for HPV DNA testing. But if they are positive, then you evaluate the positiveness of the lesion and then decide about the type of the treatment you consider, either ablation or excision. If you are suspicious about invasive cancer, from a peripheral center, they would be referred to a higher center. So that is the screen and treat approach. And when it comes to screen, triage, and treat approach, especially if you are using cytology, if it is negative, we rescreen after 3 years. If it is anything ascus, we do reflex HPV. If it is anything LCL or more than that, we take them for colposcopy with or without biopsy. And then based upon the biopsy report and the grade of the CIN, we decide further treatment. On the other hand, if you are using primary HPV DNA screening, then if you are doing only a test which tells you whether it is positive or negative, if it is negative, you call them after 5 to 10 years. But if it is positive, again, you have to do a triage, either genotyping or colposcopy, VIA or cytology triage. And based upon the findings, you would further decide about the biopsy. And based upon the histology report, you decide about the treatments. So this is generally all of us know and all of us follow these algorithms. But it is not always that straightforward when we are dealing women in our day-to-day practice. So that's why we are here to discuss about these dilemmas or difficulties in decision making. So before actually going to the case scenarios, and it is for the purpose of the delegates who must have joined, not for the panel members. I know the panel members are all very, very experienced. So just let us revise the basics. So the first, I have just put it for my convenience sake, but anybody can answer. Dr. Anjana Chauhan, what is meant by cervical intraepithelial neoplasia? What exactly it means?
Thank you, ma'am. I'm the first, we can say, backer in this session. And madam, I really appreciate your work you do in the ISSCP for cervical cancer and awareness. And coming to the question, what is cervical intraepithelial lesion, neoplasia? This word was coined by Richard, and it means the virus infection which has led to neoplastic changes, which is affecting the squamous epithelium of the cervix. And the changes which occurs due to this infection is known as cervical intraepithelial neoplasia. These are not seen by the naked eye. This is a histological diagnosis.
Yeah.
And when it is involving less than half, 1/3 of the layer, it is called CIN1. But when it goes to half, it is 2. And when it is full, it considers CIN3, that is full thickness involvement by the what we can say microscopic involvement or nuclear changes which has occurred in the cells.
Oh, thank you very much, madam. You have very clearly explained. It is, yeah, I think the next question also you have answered. So
Okay,
CIN terminology usually, yeah,
Yes.
You said that it is a histological diagnosis.
Yeah.
Yes. Yeah.
So during
how is CIN
colposcopy
diagnosed?
also, we should not report it as a CIN1 or CIN2 because it's a purely histological diagnosis, and one must have a biopsy to label it as a CIN1, CIN2 or CIN3 like that. So during colposcopy, usually we say whether it's a low-grade lesion or a high-grade type of lesion.
Yeah, and probably when you use the sweet score, based upon the sweet score, you say it may be consistent with
Prediction, yes.
yeah, CIN1 or CIN2 or CIN3 like that. But as Dr. Anjana madam said and Dr. Bharati again, we need to understand that it is a histological diagnosis. Bhagya madam, how is CIN graded? And I think there are some changes in the classification of the CIN also now.
I think we still go on speaking CIN 1, 2, 3. I think that's gone into our heads. But I think the newer classification has actually divided it into for simplicity, into two groups. One is the LCIL, that is low-grade squamous intraepithelial lesion, and the other is the high-grade squamous intraepithelial lesion. So CIN1 and other coilocytic changes, though they are histological diagnosis, but that's classified as LCIL, and CIN2 and CIN3 are HCIL. But then we have to all agree that CIN2 is a little heterogeneous group, and sometimes we may need to do some other test to confirm whether it is really a transformative change or a proliferative change only.
Yes, madam, it's very true. So we are, as you said, we are all familiar with the terminology of CIN1, 2, 3, and we feel if it is CIN1, yes, okay, we can observe. CIN2, CIN3, we need to add something like that. It is already ingrained into our minds. But even the latest classification, even in the histological diagnosis, as you said, they're using the word LSIL histology and HSIL histology. So that is what, and they have made it into two compartments.
Pathologists still report as CIN. So actually the reporting also has not changed of late. So I think it will take some time. We still follow that CIN classification, but I think we'll have to change.
Yeah, and but we need to have an idea because if somebody who is already a little advanced in the pathology, they may say in histology LSIL or HSIL, then we get confused why they have given it. It is not a histology, but we can always verify from them if you have a doubt, and we can clarify that yes, there is a change happening in the terminology. So that is very clear, I hope, to all the delegates who are joined. Then what is the incidence of CIN, Dr. Jeena Baburaj? Different grades of CIN.
First of all, I must thank Anjusoni madam and Leela madam for giving me this opportunity. And also I thank the Shruti from Kerala. She's for giving such an introduction. But madam, you have asked me a difficult question. What is the incidence of CIN to me? Yeah, the incidence of CIN varies from, in case CIN1, CIN2 and CIN3, these incidences varies. But HSL, this actual precancerous conditions of CIN is around 2%, 2 to 3%. And the CIN1 incidence is much more higher, around 10, 12, 15%. That's true precancerous condition is HSIL, that is 2 to 3%. I think it is throughout India.
Okay, madam. So relatively, you see, I mean, when you see, like when you screen 100 women, maybe you see 3, 4 being positive. You won't see huge numbers, especially with cytology or whatever it is. Even the HPV incidence also varies from, the prevalence of HPV infection varies between 5 to 10% in different geographies of our country. So in that, if you further evaluate, you won't see very huge numbers of CIN when you talk in small percentages. But when you talk about the whole country and the women who are supposed to be screened, the numbers are definitely huge. That is how we have to think of.
In Kerala, the incidence is 2%, madam. HSIL incidence is 2%, and LSIL is around 14%, around to 14%. LSIL incidence.
That is, you're talking about the cytology.
Yeah, ma'am.
Okay. Fine. What is the purpose of treating CIN? Dr. Jyoti Meena, she's from All India Institute.
Thank you, ma'am. Thank you for
Okay. Yeah.
So basically, the purpose of treating CIN is to treat the women who are at high risk of developing invasive cancer. So basically, the goal is to prevent the possible progression of the cancer, but we simultaneously we have to avoid over treatment also, because sometimes these lesions can spontaneously regress and the treatment can have morbid effects. So those who are at high risk and those who are at risk of developing cancer, they should be followed, and not that all CIN1 or thinking that a patient is HPV positive, you should not treat all these patients, because in some patients, the lesions will regress on its own within 1 year, 1 to 2 years. So the management should not be dictated by histopathology report, but it should also incorporate the patient's characteristic, the risk of CIN3, which will be determined by the current results as well as the past history also. And you have to keep a balance between the benefit versus harm while doing the treatment.
Yes, so that's why we have to individualize the treatment once you make a diagnosis of CIN. So as you have rightly said, many factors we need to consider: the age, the parity, the grade of the CIN, persistence of CIN. All these things are very, very important when you consider the treatment. So anyway, you have also explained the same thing. I think Professor Meeta Gupta is not there, but you have already covered that answer, that is treatment needed for all grades of CIN? No, it is not. You have to individualize, as you have said rightly, where you think the follow-up and with close observation is possible. Definitely you can wait. You need not consider treatment, but certain situations, definitely you need to consider the treatment where the risk of progression to invasive cancer is quite higher. Definitely you should not ignore. I think these basics must be very clear to all of us and to the delegates. That's why I just brought out these points. Now let us move on to the case scenarios. These are the some of the answers we have already discussed, so I skip it. But one of the studies from where I have taken the incidence of different types of CIN1, that means histologically proven, the incidence was found to be 2.3%. CIN2 was 0.5% and CIN3 is 0.4%, but it can vary from place to place, from the institute to institute. Okay. So coming to scenario 1, she's a 28-year-old lady, married for the last 2 years. She's planning pregnancy and she goes to her gynecologist with persistent white discharge, and the gynecologist did HPV testing. It was only a HPV testing, no cytology was done. It was HPV 16 as well as other high-risk HPV types positive, because of late now with the advent of this primary HPV screening, some places they are only doing the straight away HPV testing. And the test what she had was a COBAS HPV, which is a validated HPV testing. And she was found to be positive for 16 and other high-risk types. So Dr. Reena Srivatsava, madam, are
Yes,
you
I'm
around? Yeah. So how will you manage, or how will you tackle this lady, madam? What would be your choices, or how would you proceed further?
See, this woman is she's symptomatic with persistent white discharge, number 1, and she's positive for high-risk HPV, that is 16, and other high-risk types also. So straightforward, a colposcopy, I would like to get it done in this case. Triage with colposcopy, and depending upon the findings, what are the findings, histopathology, and then we can go forwards.
Madam, what is your thought about doing HPV testing for a woman below 30 years of age in general population? If, let us say she's not immunocompromised or anything, do you do routinely in your practice?
Routinely, we are not doing, but if patients of higher strata, they know about it and they come for it, definitely we are getting it done, because it is advocated after 25 years in high risk settings also. So why not? The sexuality is starting at a very early age these days, and the girls who know all about it and they are asking for it, why not to get it done?
Okay. What about Dr. Jyoti? What are your thoughts?
Ma'am, actually,
Routinely, from my side, I'm not getting it done. But
routinely
if the
we are
patient is
also
there,
not doing, because the chances of getting HPV positivity is higher in women who are less than 30. So there is more chances of getting over treatment or over management will be done for these patients. I think we can even try, if the patient you think that can go will not come for follow-up, you can go straight forward with colposcopy also, but we can try it with cytology also.
this patient is having a persistent discharge also. That
Yes,
is an
ma'am,
important
persistent,
point.
but that depends on how is her cervix looking like.
Yes.
Persistent discharge can be because of cervicitis infections also. So that thing
And she
also.
must have got it treated because the term used is persistent. So
Yeah,
definitely she will need a triage.
definitely. So I will like to see her per speculum examination also.
Yeah.
But in developed, madam, in developed countries, they advise HPV testing after 25 years of age.
Yes,
as
ma'am,
a primary screening
yeah, ma'am.
modality.
They are
Primary screening of can be done by HPV itself, and yes, we should start at 25 years. This lady is 28 years old, and she must be active sexually most probably now in today's
She's married for 2 years.
Of
But
course,
it's
she can
pregnant after 30 years.
He may be having a relationship for last 8 to 10 years. So 10-year time is a very important time for CIN to progress to cervical cancer. We are in OPD, we are getting early age women who are developing cervical cancer. So if we start screening at an earlier age, it's a good option. And we should not say that we will start at 30 years or after that. Starting screening at age 25 years is good enough.
Ma'am, it depends on the resource setting also. If you are sitting in a resource setting, definitely you can start. There's no harm. But being in India, I think that is the reason why, because most of the tests are not validated. Definitely COBAS, she got COBAS done, then okay, validated test is okay.
But the guideline says it is after 30 years.
Yeah.
So for routine screening.
Just
The
for
guideline says that for high resource settings, it should be started at 25, and like a place we are working over like India, it should be started at 30 years. These are the two guidelines over there.
Yes, madam.
And see, India is having a varied population. Some people are not knowing anything and others are knowing everything. So you cannot just limit it to that this thing guideline ki 30 se pehle karenge hi nahi. This is not true.
For asymptomatic patients, madam, for as a screening procedure, we start HPV DNA testing after 30 years for asymptomatic patients. In asymptomatic patients, we can start earlier.
Yes, ma'am.
Yeah, so this is always
guidelines are to guide you. They are not the rules. So one must decide on our clients, how educated she
what
is.
type of population we are dealing with, we have to keep it in mind.
Yeah, I understand all the discussion. So it is always a controversial thing doing HPV testing before 30 years of age. In a immunocompromised, yes, definitely from the age of 25, one can start doing it. But general population, it's a debatable whether we should start before 30 or after 30 because of the problems involved, because we want the natural clearance to happen, and sometimes we may unnecessarily over-treat. All these things are there. So as much as possible, you can screen between 25 and 30 using a cytology rather than HPV. You can at least delay doing HPV probably till the age of 30. So that may be a better option to avoid confusions in our clinical management. And as rightly said, persistent vaginal discharge or white discharge is also one of the indications for colposcopy. Even the cytology and the HPV come negative. So that also the indication for colposcopy. So this is the same guideline I have put here. So by all means, she is eligible to have colposcopy for two reasons, as Reena madam has rightly said. One is the symptom, the other one is the positive HPV testing. Here, she's already had a genotype. So we know what the genotype is, and the genotype is again 16. So when you see a genotyping of 16 or 18 positive, definitely we subject them to colposcopy. So she had colposcopy. And these are the colposcopy images of this lady. The first one is the saline green filter, and this one is after application of acetic acid, and this one. So yeah, anybody can, or maybe Reena madam, because you wanted to do colposcopy, and
Yes,
these are the
she's
images.
yeah, the cervix is showing aceto-white areas, not very thick, almost
Yes,
thin,
madam.
but on one side the margins are very clear, and vessels are not seen,
Yes, ma'am.
and it is Lugol's negative also.
Yeah, so roughly the sweet score would be
That
around.
it is involving
6.
almost 2 quadrants of
Yes,
the
ma'am.
cervix, that is most of the anterior lip,
Yes,
and from there biopsy should be taken.
yeah, madam. So as you have said, because she had a colposcopy and we are seeing some aceto-white, so she had biopsy and the report came as SIN1. I think the features are also fitting into the low-grade abnormality, and
Yes.
it is SIN1. So yeah, we'll ask Yashodhara madam, what would you do for this lady, madam? Because now we have, she's a 28-year, keen to plan pregnancy, and the biopsy has come as a SIN1. What would you do, madam, Dr. Yashodhara?
Yes, yes. She has undergone HPV testing. The 2 high-grade oncogen types are found, and along with it, the colposcopy triaging was done. And on colposcopy, something must have been found, must be there. That's why the woman was subjected to histopathological examination. As you have seen in the picture, there on the lower edge of the cervix, on the right lower end, there abnormal vessels were there, and high-grade the satellite lesion was also there in that picture. So this was a high-risk case, including if you can see the second picture, this is the saline picture, and yes, this is the green filter picture. Here, this lesion is.
Madam, I think that is a Nebothian cyst with a tuft
Yes,
of vessels, madam.
that is all.
a
That is
Nebothian
present before in the
Yes,
first
madam.
photograph
Here also
also.
you are seeing this, madam. This may
Yes.
not be
Abnormal vessel arcade was present. I have seen it in the Zoom. The lesion which you are saying is Nebothian cyst. Actually, abnormal vessels were present there. If you see in original picture, you will find out. So, anyways, that's why the cervix is bad one. So that's why colposcopy was done, and then the gynecologist has rightly advised her for biopsy. Fortunately for the patient, it is only CIN1. So CIN1 agar hai to yes, of course we can wait, and she under treatment, under guidance, she can go for further management. Like whenever CIN1 is there, the previous cytology test, if it was done, that we will look if it was LSIL or if it was HSIL. Okay. So if it was HSIL, then of course diagnostic excisional procedures are indicated, because the HPV positivity, colposcopy has advised the biopsy and NCIN1. Along with it, the cytology is showing HSIL. So diagnostic excisional procedure must be done to confirm the diagnosis. If LSIL is there, and then we advise this woman to wait. We advise her follow-up, and after 1 year, we'll subject her for further testing of HPV with the cytology testing. So this is
Madam,
how we
this lady did not have any cytology in the past.
Yes.
Straight away had a HPV testing, and after that colposcopy. So do you recommend that we need to do a cytology for her now, or based upon the biopsy report, can we decide about treating versus following her up?
If she is not having this cytology, then it's okay. A patient is already 3 diagnostic procedures were done on that woman. That is HPV, colposcopy, and then biopsy. And CIN1 has confirmed. So we advise this patient follow-up, and we advise her to for the repeat testing after 6 months and 1 year. because CIN1, there are very less chances of progressing it to higher CIN2 and 3. It takes time, and many a times HPV virus, as Dr. Jyoti has already mentioned, that HPV may get cleared from the body with the increase in the immunity. So in this case, we will advise her to follow at 6 months and then at 1 year.
So basically, you like to put her, instead of offering any treatment, you want to reassure her and call her back after 6
Yes.
months for a repeat testing. That is what your plan is, no, madam?
Yes.
Ashok Raman.
Yes. Yes.
She is planning for pregnancy.
Yeah, Dr. Anjana Chauhan, madam, do you have any difference of opinion? What do you like to do, madam?
There is a lesion is very huge. It is involving the two of the cervix, and we have to think about a pregnancy also. If
Yes,
she is
madam.
planning for pregnancy, then I think so there will be aggravation of the lesion. So probably I will like to do an ablative procedure on this woman because she is a CIN1. It is nearly involving what we can say 1/3 of the cervix. So a simple ablative procedure like cryo or thermal ablation will treat our lesion because she is having a high grade lesion. So we want to treat. If she was a low grade, then we could have left her. High grade, sorry, HPV. I mean to say HPV.
Yes, I
If she was
understand.
a low grade. So
But
I think adding an ablation lesion will be good for her. And if she's planning for pregnancy, because she is married 2 years, they will go for pregnancy. The pregnancy is there, then it will be aggravating. That is my opinion.
But
No,
she's
she's
having
only 28 years old and the region is low grade. So I
low grade.
think we should wait for 1 year, follow her up,
Yes.
and then decide about the treatment.
Follow
It's
up
not
at 1 year.
Yes.
not a high grade lesion, only CIN1 has come out on
Yeah.
biopsy.
Yes, yes.
Yeah, so in this 1 year, can we allow her to plan pregnancy or not? Or should she wait till she clears her infection? What should we advise her? Because she's also worried about her pregnancy.
I think we can advise her because
She can
yes,
plan.
she can plan pregnancy, of course.
Yeah,
Yes, she
so-
can plan.
Okay. Bhagya madam, are you around? Bhagya madam. I don't know whether
We will
Bhagya madam
dis-
is around or not.
We will discuss the pros and cons with the patient.
Yeah.
Whether
Okay.
she is waiting, it's okay, or we will do an ablative procedure and after 3 months, 6 months she conceive, it's okay. That depends. After the discussing with the patient, we can make a proper treatment here. Whether because it is HPV high risk, cysteine is positive, so very good chance for progression. And histopathology it is CIN1, so
Yes.
regression chance is also there. So
Yeah.
today we will discuss all those things with the patient and with her consent. We can do both these optional. Both option we can take.
Whenever we do CIN1, when the ablative procedure we perform like thermal ablation if we did. So we need to follow this patient after 3 months and after 6 months.
There are webinars.
Takes 6 months for that lesion to heal. So during this duration of 6 months, we cannot advise her to go for pregnancy. And pathologically, the lesion is only CIN1. HPV is there, infection is there, which may get cleared. And cytological changes which has occurred following infection are only of CIN1. So ablative procedures are not, in my opinion, are not indicated in this case.
Ablative procedure, madam, healing will take only 1.5 months, not 3 months. So after 1.5 months, she
6
can even
weeks.
Usually
Usually 6 weeks. They
weeks.
we advise them about 4 to 6 weeks abstinence.
Yeah.
Then after that, they can, as such, ablation also doesn't have any adverse effects on the pregnancy outcome. Yeah, I think this is, it's not a very easy decision to decide like straight away offering her treatment, thermal ablation and other things. What do you do, Dr. Jyoti? Are you around?
Ma'am, yes, ma'am.
Yeah.
Yes, ma'am. So, in my opinion, we can follow her up. But if she has persistent discharge, then ablation can also be a treatment choice for this patient. Because she is having persistent discharge until the area is not ablated, she might keep on having this persistent discharge also.
Yes.
So we can explain the patient, and in my opinion, she can go for pregnancy also, because even if we are going for a repeat cytology at 1 year, that can be done during pregnancy also, and we
Yeah.
can follow even with columns.
Yeah, so both the options are possible in this case. One is observation encouraging her to become pregnant, but she also has a symptom. Forget about the HPV-16 thing. So if she's really worried about her symptom and also worried about the HPV-16, as Dr. Anjana madam and Dr. Jyoti, everybody says, probably ablation can be considered, and ablation doesn't have any adverse effects on pregnancy. Using a thermal ablation or cryo, whatever is, and probably thermal ablation nowadays is very easier to do. Just, but at the same time, you have to ablate the entire transformation zone, not that acetowhite area. So that is the basic principle one has to understand. So both the options, but we need to talk to the patient, as Dr. Gina has rightly said, counsel her, explain to her, and then go ahead with the procedure. So I just brought up this case because these are the common things we are seeing. Very many young women are getting HPV testing done, and we'll have these kind of dilemmas in managing. So thank you for all your nice inputs and discussion. So let us move on to the next case. So this is already Madam has, Dr. Yashodhara Madam was trying to explain. This is actually 2018 FOXY recommendations. Those days we were doing more and more of a cytology based. So that's why they have given this flow chart saying that if you diagnose CIN on biopsy and the preceding HPV or cytology is ASCUS and LSIL, then you do the code. This is for general population. I mean, not somebody who is planning for pregnancy. This is generally somebody who is diagnosed on CIN1. There is no rush to go ahead and do the treatment immediately. If the cytology is low grade, you can always follow them up. And if it is persistent for more than 2 years, that means every year you repeat it, and if it is positive, then you will be doing the treatment. But on the other hand, CIN1 in the context of high-grade smear abnormality, then probably you would be doing, follow-up at shorter intervals, or you would be going for excisional procedures or whatever based upon, because when you see a high-grade cytology, but the biopsy is showing CIN1, that means there is a disparity between the cytology and the biopsy. Then you would be going for excisional treatments. Whereas the cytology and the biopsy are correlating, then you can go for ablative treatments in CIN1. So that was our 2018 recommendation. Similar recommendation they also have put for women who were desirous of pregnancy and less than 30 years of age, going with the cytology report. But what I feel is of late, if we are moving more and more towards primary HPV testing, I think we probably need to look into changing of the our management guidelines also probably. So here they have taken the cytology into consideration, and based upon the cytology, they have allowed the women to be either on follow-up or on treatment. So this is our FOXY 2018 recommendations, but we have nicely discussed about ablation versus follow-up, observation with a close follow-up. That is what usually we can do in young women who are desirous of pregnancy. So you all know the natural progression, persistence, regression rates of CIN. So if you say CIN1, almost 57% regress, and the progression to invasive cancer is only 1%. On the other hand, if you have CIN3, the progression risk is, invasive cancer is 12%. So CIN1 definitely by all means can be followed up with without doing any aggressive treatments or anything, and especially in younger women. So that is the message. So let us move on to the next scenario. 32 years, para-1, live-1, and she already has one baby, now wants to conceive again. And she had a co-testing LBC, LSIL, and HPV is positive. So we don't know the genotype, but HPV is positive, and the cytology is LSIL. Madam Anjana Chauhan, madam, I think it's again your turn.
Madam, I will definitely like to go for a colposcopy as she's planning for a second child. There can be two options because it is a low-grade lesion. Positive, we can keep her on observation, repeat, because a low-grade lesion you can follow up or do a repeat test after 6 months. But since he is planning for the, definitely I will go for colposcopy.
Okay. So actually there is a slight change in the recommendations. I think in the earlier they were saying for ascus and LCL reflex HPV. But when you are doing a co-testing, when you see HPV positive with whatever cytology, we are the recommendations are going for
colposcopy.
Yeah, so positive means definitely it is a high risk. We don't know the type, but it is one of the 13 or 14 high risk HPV types positive, and the smear also shows LSIL. So that's why, yeah. So madam feels that she should go for colposcopy. So I hope all the panel members agree for doing colposcopy.
Yes.
Yes.
Yeah. So okay. So let us do colposcopy and see. Yeah. So these are the colposcopy images. So this is after saline. This is after green filter. And if you see here, I think the lesion is very. It's not very clear here. Very thin lesion. Yeah, thin estovite with the diffuse borders. But when you try to open up with this endocervical speculum, you are able to see the lesion going into the endocervical canal. So this is the lesion is more towards the endocervical canal. And this is, of course, this is not a very clear picture, but all this area, wherever we are seeing this thin estovite, all that has not taken up the iodine. So these are the colposcopy pictures. So following that colposcopy, she also had biopsy, and the HPE report has come as a CIN2, and her, I have not mentioned here, but her endocervical curettage was normal. So what is the plan of action? Dr. Bharati, what will you do for this lady? She's also keen to conceive, but here the lesion is CIN2, and it is actually, you've seen it slightly going into the endocervical canal, but you're still able to see the entire limit of the lesion.
Yes, we are able to see the entire lesion, but the lesion is extending into the endocervical canal. So we can grade it as a high-grade type of lesion. And we're not able to see the lesion completely on the ectocervix. And the patient is also interested in future pregnancy. So definitely one needs to have a treatment. Again, here it is a SIN2. SIN2 is again a confusing situation. Sometimes it may be a SIN3 or SIN2. So to get it clear, we should advise immunohistochemistry like P16 and Ki67 if the facilities are available and if the patient is, of course, affording for that and ready to do that. But as a whole, if the patient is not for the immunohisto and we are also not having the facilities, then straight away we can go for the treatment. In this case, ablation, I don't think it will be helpful, but we must go for an excisional treatment and then send it again for histopathology, see if the margins are clear or the margins are yet are involved by the disease. And depending upon that, the further management and advice to the patient should be done.
So, okay. So you have nicely explained everything about how to manage a case of CIN2. Very nicely, you have brought the point of using IHC. How does IHC help? So what kind of interpretation we do with IHC?
So it will help differentiate between the SIN2 and SIN3. The markers used are usually P16 and Ki67. So whenever the lesion is SIN3, the entire stain will be taken up by the all the layers of the epithelium, and it is very clear picture of CIN3. If it is not stained, entire epithelial layers are not stained, then it may be a SIN2 type of lesion.
Yeah. Yes.
But immunohistochemistry is going to help in upgrading the CIN2 lesion. If it is associated with positivity of the immunohistochemistry, then it is upgraded.
Yeah.
Yes,
CIN2 goes to a higher version.
Yes, madam. So if it is a complete block positivity, then definitely the risk of progression to CIN3 is quite high. If it is only a patchy IHC positivity, then you can say that it is not an aggressive thing. Is Bhagya madam around?
Madam, I just want to add one thing.
Yeah. Sorry, madam. Anjana madam, you are saying something.
Colposcopic features, no, madam, I just want to highlight something that whenever we do a colposcopy, we have to mention that it is what type of transmission zone. This is type
Yes.
2 transmission zone. So
Yes.
whenever you do any ablation procedure, you will never go inside the cervix. So when there's a type 2, it's better to go for excision, even if it is a low grade lesion. In a type 1, ablation procedures are indicated. For type 2, if it is a low grade lesion or still 2, it's better to go for excision. And we have to have even if we are going for a leaf, we have to have a hat shape so we can get the endocervical tissue also. So these are the point only I want to highlight.
Yeah.
And the one thing is that, madam, this patient is planning for pregnancy. So after this lip excisional procedure, the chance of preterm labor is very high. And
No,
if
no,
the
madam, I'm not saying deep. I'm not saying deep. See, there are
not commenting on your decision or opinion, madam. Just as a patient, for this case, I am discussing that.
So before treating, we
For
are going
the
to before treating, we are
So
going to
if it
explain
is
to the
CI
patient, that she
Yeah,
may
ma'am,
have a
see, this
preterm
is,
labor.
and please hear my point, ma'am.
Yeah.
If it is this immunohistochemistry is positive, then we can go for lip excision. If it is negative, let them explain, and then we can we wait for 1 year for getting a pregnancy and then go for the treatment. That is the dilemma here, I think.
Yeah. Okay.
I will not like to wait, madam. I will like to go for excision because she's having a huge,
Yes.
and this will be a shallow leak. So it's not going to affect a pregnancy. It's going to be superficial 3 to 4 mm. So it's not going to affect a pregnancy at all.
And
Yeah.
one more thing, madam,
Again, the type of excision is very
One thing
important.
I want to add. So if she is concerned about progression of the disease to SIN 3 and then to cancer, rather than conceiving and having a baby, that point should also be discussed with the patient.
Yeah.
Nobody will like to have a cancer.
Yeah, that should also be discussed with the patient.
Yeah.
And another option, can we go for this HPV genotyping? If it is high risk 16 and 18, definitely treatment. And low risk.
Yeah, that can also be done. That can also be done. The
It can
genotyping.
also be done, but it's not necessary that HPV DNA in 18 will come positive. Already the cytological changes have developed. So maybe there are chances that HPV DNA comes negative.
Nay, once as madam said, once you are seeing a histological changes means already the infection has produced some effect.
So to know the genotype, whether it is 16, 18 or non-16, 18.
Even if it is other HPV,
At this stage, it is already a high-grade lesion.
Yes.
So going for a DNA test, HPV testing, I don't think is required.
Yeah. Probably before doing colposcopy, if you wanted to do that is fine, but you have already done colposcopy, you have already done biopsy. Probably doing HPV now and later after the treatment as a test of cure, you want to see whether the patient has cleared as infection. Maybe for that reason you can consider. But as far as for taking a decision for management, probably this HPV genotype may not be of great help. I think Bhagya madam has left, I think. Is she around?
No, ma'am, she is there.
At some meeting.
Acha, yeah. She's there.
Yeah. What do you say, Dr. Jyoti? I think I'm asking everybody.
No, ma'am, this is okay. But one thing I want to say is because the lesion is extending into endocervix also, so excision should be a good option. Because we have to
excision should be done. Yes.
So usually when there is an endocervical extension, definitely we consider for excision. So the learning points for us here is when you have a CIN2 at biopsy, wherever possible, I think we should definitely go for IHC. That is a must to help us to decide about further management. Because here the situation is again, young lady wants to plan pregnancy, these kind of things. If it is nothing like that, definitely we'll say, okay, go ahead and do the excision. That's a straightforward thing we decide. But when it comes to pregnancy, these dilemmas do arise. Very, very rarely, I think, if the extension into the endocervical canal is not too much, and where you use the thermal ablator probe with a nipple probe where it can go and touch that lesion and destroy that lesion. I think rarely, selectively in SIN2 also, where IHC is negative, you can consider ablation again with a lot of counseling and other things. So that is a special situation. But
That could
as
work
such-
for only a very small extension.
Yes, very small extension, but not so deep into the thing. And pregnancy effects depend upon the type of the excision. If you do, I think type 1 and type 2, probably you won't destroy too much of a endocervical canal. You won't take too much of endocervical canal. Then relatively the risk of preterm labors and all those things are lesser. But if you do type 3 excision, definitely the risk is higher. So I think again the take-home message for the audience is CIN2 is a dicey situation. Using up IHC wherever possible is important. And of course, again, pregnancy, CIN2, endocervical extension, one has to be very careful about counseling, taking decision for ablation versus excision. But wherever it is indicated, we have to go ahead with the excision rather than compromising, unless the patient is very particular, that doesn't want to take any risk of pregnancy complications and wants to try ablation. So that is definitely it's a case based situation, but not as a routine practice. So that is what we have to give the message. And these are again our FOXI guidelines. So in CIN2 and other things, generally what we have discussed is the thing. We go for excision procedures. But some situations, even CIN2 also has got some regression rate. Then probably if there is no endocervical extension and other things, it's a type 1, you have seen everything very clearly. Then probably you may need to very close follow-up. But that is some individual cases, not on a routine basis. Yeah, so CIN2 and 3 young women desirous of pregnancy. As you all have rightly said, follow up at 6 months as per our FOXI recommendations. And if the lesion persists, repeat cytology and colposcopy at 1 year. So this is the flow chart. You all again have said if facilities are there, do the IHC testing. If it is negative, yes, you can follow them up. If it is positive, then definitely you have to consider for a definitive treatment. I think this message is very clear. So here definitely the IHC plays an important role. This is this is a picture like Dr. Bharati was saying about block positivity versus patchy positivity, where all the layers are stained, immunohistochemistry and other. So in CIN3 and CIN2, you will see IHC pictures like this. This is for Ki67 and this is for this one P16 and this is testin. So here you are seeing the entire, all the layers are stained brown, and here also almost all the layers, but here you are seeing only the lower parts. So that is yes, yeah. That's how it will help you to decide about your clinical management. Yeah, so this is the ASCCP. Here also they have mentioned very clearly. Below 25 years, anyway, we are not doing any not routinely we are screening for women below 25. So 25 and above, if concerns about treatment effects on future pregnancy outweigh concerns about cancer. But here our lady has already has 1 child and she's 30 plus. So we have to discuss her about definitive treatment versus the pregnancy and the risk of progression and all these things. And accordingly, we can take a call. So that is about our second case. Then coming to, yeah, this is just, I have put it, sometimes I don't have any case of CIN in pregnancy. But if you see pregnant women with CIN1, then follow up without any treatment till the pregnancy is over. CIN2 and 3, again follow up with cytology and colposcopy at interval of 3 months and 6 weeks postpartum.
Yes, children, panel discussion.
As long as there is no invasive disease, no active treatment during pregnancy. So once you see an invasive disease, then of course, on the gestation, you have to decide how you want to plan. So anyway, I'm not going to discuss about this aspect. So let us move on to the third case. So she's a 55-year-old Paris lady, persistent white discharge. She had co-testing, LBC is ascus and HPV positive. So Bhagya madam is not here. So after Bhagya madam,
Nice.
yes.
Myself, ma'am. Yeah.
Yeah. You can take
Yes.
this case. What you want to do?
She's 55-year-old lady.
Yes.
And caught testing LBC positive, LBC is ascus and HPV is positive.
Yes.
So definitely I will do a colposcopy for this patient, ma'am.
Yeah.
So colposcopy is indicated, both the HPV and ascus.
So what are the problems you face when you do colposcopy for a postmenopausal woman? You must
The
have
problem is that sometimes the transformation zone, it is difficult to see. Maybe type 3 transformation zone, type 2 or type 3 transformation zone. So, but we can take endocervical curettings in such cases and see whether there's endocervical lesions, endocervical curettings positive or any abnormal lesions in the ectocervix also. If it is there, took a biopsy. And then depending on the biopsy report, we can treat it.
Yeah, it's not only about seeing the transformation zone, sometimes even putting the speculum, looking at the entire cervix and everything is not always very easy. So doing a colposcopy in a postmenopausal woman is always a challenge.
Always
55 years, maybe, but sometimes you have to do it women 60, 65, rarely.
Yes.
You'll definitely have a tough time in
60, 65
interpreting
is
the
very
things
difficult.
also. Yes.
Centralizing the service is very difficult in 65 above 60.
Yes.
Sometimes it is flushed with the vault. So very difficult to see. And there is severe hypoestrogenism.
Yes.
So the acetovidness, particular lesions may be there.
Yes.
It's very difficult to interpret the acetovidness and also the iodine.
Yes, all these difficulties are there. So I think everybody agrees that this lady needs colposcopy. Same thing, having a wide discharge at the age of 55 and co-testing showing ascus and HPV positive. What do you say, madam? Reena, madam?
Yes, definitely she requires. She needs a triaging.
Yeah, okay. So she had the colposcopy and this is her colposcopy picture. It's not looking very good.
Yes, difficult to interpret.
Difficult to
The
interpret.
acetovid area is there in the third picture, but transformation zone we can't make whether it's a type 2, type 3.
Yeah, it's very difficult to interpret whether it is type 2, type 3 or something like that. Maybe I feel this must be the tiny os. And actually I had a lot of difficulty in doing colposcopy, even exposing the cervix and everything. And I could see some vascular patterns here. Yeah, and then as you said, the entire area has
iodine negative.
Iodine negative. But here some esto white areas I'm seeing here and some kind of a, I don't know whether it's some kind of a peeling of epithelium or whatever it is. All these things are, and what is again another difficulty when you want to do after colposcopy, what is other difficulties you face? Suppose in this lady, I had a bit of difficulty in taking a biopsy. Taking biopsy when the cervix is flat is also not very
easy to take biopsy.
Yes, especially punch biopsies. So if you have a difficulty in taking punch biopsies, what else we can do?
Can take a scrape.
Scrapings
like using the knife and we can take some scrapings.
What about using a small loop and a biopsy?
Leap biopsy can be done.
Yes.
That is must be.
What do you say, madam? Anjana, madam, Dr. Jyoti?
We can do a loop biopsy. That will be the most best way to take a biopsy.
Yeah, so most of the times it's very difficult to catch the tissue with the punch. Even you stabilize the cervix, you may not be able to get the tissue. Then you can consider doing a small loop biopsies from the abnormal areas. And that can be sent for histopathological examination. So I had the same problem. Initial report, they said there is no adequate tissue. Then a small loop biopsy, it was showing CCC. So yeah, I think, Dr. Reena, you have already answered. So the next person is...
I will answer, madam.
Please.
Because the loop biopsy, it is CIN3. We look for the loop with this specimen, if the margins are negative, this ectocervical endocervical margin is negative and there is no invasion, the treatment is sufficient for this lady.
No,
And she
here,
will
no, I
cover.
just sorry for interrupting. It is not a complete excision of the lesion.
Oh, it's only a
small biopsy.
CCC will be required.
So now she will be requiring excision.
She will require excision or a deep cone, madam. She
If
will
the
require
excision is
excision.
difficult in these cases,
She will require a deep cone biopsy.
Cone, we can go for a cone also for this because we have to, in this, it is just a superficial leap, then we can't comment on the margins also. So we have to take a deeper, a diagnostic one now to look for the deeper margins and all. So we can go for a cone also because the lesion is very broad, leaps in, we can take cone also.
Yeah, so doing again loop excisions, cones in postmenopausal also not very
this
easy.
is possible for
ECC can be done, endocervical curettage.
Definitely ECC will be done because colposcopy is inadequate. So we have to do ECC also.
Yes.
Patient can go for hysterectomy also.
I will advise hysterectomy.
Yeah, that's why I have put this case.
Yes, I will
How many
advise.
want to do hysterectomy or how many want to do?
Counseling with the patient. And about all the process,
Yeah,
if she wants to follow up, if she wants to keep a uterus back, then we have to work out. Otherwise, we can go for hysterectomy.
But madam, suppose if you have done hysterectomy, for this. And the only issue here is, yeah,
if
the
she's
only
having
issue here
invasion,
is,
then we'll miss it.
madam, tell me, madam, Anjana, madam, you're saying something.
If she's having invasion, because we have taken a biopsy from one area only. So we have to do a cone before subjecting her to hysterectomy. Because if she's having invasion, then the treatment will be inadequate, or we are doing hysterectomy for invasive carcinoma. That is not advisable.
Yes, madam, that is what I just wanted to say. So these are again very difficult situations, and most of the places women request you to do hysterectomy, and they say that anyway there is CIN3, I want to have hysterectomy. But as you have rightly said, we have taken only a small biopsy in one area, even though that is not showing any invasion, but we don't know about the other parts. So ideally, we can attempt either a cone or a proper leap excision, and then after that, we can decide about hysterectomy. That is the standard way of approach, so that we will not miss any invasive carcinomas in the post-hysterectomy specimen. So if you have a invasive component in the post-hysterectomy specimen, then definitely we have to subject her to further treatments and other things. So
because recurrences are more if we do just for CIN3, we do hysterectomy, the recurrences are more at the vault. So we have to be very careful.
Yes. So that's why we should never jump straight away to do hysterectomies in CIN3.
One point, madam, this is a loop biopsy only from one place.
Yes.
You can have multiple loops also, no? You are anyway doing biopsy. So you can, like a 4-quadrant punch biopsy we used to take. We can take biopsy with a loop from 4 different sites.
Okay.
Even then, it is not going to cover the whole tissue.
Yeah.
Once it is CIN3, even in a small loop, we should do a diagnostic one now, either a bigger loop or we should do a cone biopsy so that we can comment upon the margins also. Now, the problem will be if the margins are positive, then what we should do? Either we should do a repeat cone or then we should do a hysterectomy. That is a different question.
So, yeah. So, these are all difficult scenarios for us. It's not that easy for us where you can do the procedure without any problem, straightforward, that's fine. But in postmenopausal, again, you have all these issues. So I know majority say that, okay, it's better to do hysterectomy, but we should not miss that invasive component and we should not undertreat a woman. So that is the message we want to give. Yeah, of course, straightforward CIN3, definitely everybody recommends excisional treatments. There is nothing like doing an ablation in CIN3. We have to go for either cone or excision, loop excision, whichever is feasible, possible, depending upon the situation, we would be doing it. The same thing, yeah. So I think that is very clear. So let us move on to the scenario. I think, do we still have time for this scenario or are we running late?
What time, madam, will take?
Just it is another, this is the last one, madam.
Yeah, it's okay. Then
Yeah, I think, ma'am, we should go ahead. I think
we should
it's
go ahead.
good
We should go ahead.
running.
Okay,
Yeah.
okay. Just this is the last one. Yeah. Okay. So she's a 40-year-old, para 2, live 2, complains of irregular cycles, cervical punch biopsy elsewhere, and she was referred with this biopsy report of query squamous cell carcinoma in situ or invasive. So with this report, she came to us. And what will you do if somebody comes with this kind of a report? Yeah, anyway, Madam Jyoti, you will be seeing these kind of cases quite often at times.
So, ma'am, one problem is she is having irregular cycles, and another thing is she came with this report. So, first, I will like to review the report.
Yes.
I will like to do a slide block review. And besides this, I will also like to do her endometrial aspiration in ECC also. And if suppose if she, the slide block is not available, then I would like to look for the gross, what is her cervical conditions, and will like to take a biopsy. If the growth is visible, then I can directly take a biopsy or can go for a colposcopic guided biopsy also for this patient along with AECC.
Yes. So the message is when you get these reports, ideally you should get it reviewed by your own pathologist, especially the oncopathologist. And that is always possible in big centers, but in smaller places. But still, we need to try to do this. Otherwise, as you have rightly said, we need to re-examine the woman, and probably I think it is a blind biopsy. It's not like a colposcopic guided biopsy. So if you do a colposcopy and actually see the cervix and take a proper biopsy, I think that will give you a reasonably good information. So this is her colposcopy pictures. So this is after saline and this is after green filter. And after acetic acid applications, Lugol's iodine, and I have used this speculum to see. And what do you feel like this cervix, Dr. Jyoti?
Ma'am, anteriorly and on anterior lip on saline and green filter, it was more looking like a condyloma to me.
Yes.
It's a warty growth type.
Yes.
But on applying acetic acid in lower posterior lip also, we can see an acetovite, and I on zooming I saw it will be better if I zoom it. Then we can even see the cuffed glands also, crypt openings are also seen. So this goes in favor of a higher grade lesion to me, the lower lip especially.
Yeah.
And so I will like to take biopsy from upper lesion as well as lower lesion also.
Yeah. So the same thing we have done. We have taken the lip biopsy from upper lip. It was showing scene 1 with condylomatous pattern, and biopsy from the lower lip scene 2, but she is P16 block positivity. So more towards scene 3.
So, high grade lesion.
Yeah. So we have done this, and now we know like we need to be aggressive in treating her. We can't just leave her. Reena madam, I think you can answer this, and this is the, yeah, with this. Dr. Reena madam, are you here?
I'm talking. Hello.
Yeah, madam. So we
I'm
have
here.
the biopsies as Dr. Jyoti wanted. We have done the biopsies and the reports are with us. So, and even IHC was done. So what should we do next?
She's having a CIN1 in anterior lip with condylomatous growth, CIN2 posteriorly. She is positive for immunohistochemistry. And what about the endocervical canal?
That was normal, madam. You've done.
Normal. So because it is CIN2 and because it is IHC positive, she should be subjected to excisional procedures.
Yes, madam. So we have done the same thing. She had a complete loop excision. CIN3 actually in the, entire thing was CIN3 with condyloma in the upper lip. Endocervical margins, ectocervical margins are free. There is an endocervical gland involvement with CIN3, and there is no stromal invasion. So this is the report we have got. So should we be happy with this report, or should we do something else for this lady? Yashodhara madam or Dr. Anjana Chauhan, anybody can take this answer. Do you think the treatment is sufficient, or do we need to do anything else for this lady?
No, madam, we can observe her because we have done total legs we have done, or we have done only leaf.
We have done the
Madam.
large loop excision, madam.
Large loop
So,
excision.
madam, I think so. She can only be followed if she wants. 40 years irregular bleeding, she may people will advise her hysterectomy also in such conditions. So she can have both the options. But she's very young for hysterectomy, so we can keep her for observation. She is high risk, definitely high risk for invasive, but yet we have removed all the lesions. She is high risk. We have to keep her under close follow-up.
So you're saying something, Dr. Gina? You wanted to say something?
Yeah, madam. It's you can go for give her frequent follow because endocervical gland involvement is there, but there is no stromal invasion and the margins are free. So close follow-up is needed for this.
Anyway, for all women after treating CIN, either BCIN 1, 2, or 3, they need to be on follow-up for how many years?
20 years.
20, 25. We need to follow them up. So,
But ma'am, here I would like to see the margins of the endocervical one. Because there is CIN3 involvement, but what about the margins? Are they positive or they are negative in the specimen? Because if they are positive, then
Positive, definitely.
we are leaving the high-grade lesion inside.
Yes.
So the chances will be higher. So either we have to do a cone, if not possible, then we have to.
Yes. So when we talk about the margins in the specimen, we have to be very clear about ectocervical and endocervical margins.
Yes,
so ectocervical margins, we can actually look at colposcopy when they come for follow-up. But whereas endocervical margins, it's not easy to see. Even if you do ECC or whatever it is, you may not be able to get the thing. So if ectocervical margins are positive in the specimen, what some people say is after loop excision, usually we use the ball cautery and we coagulate the edges. So that can take care of the lesion. So when they come for follow-up, if you still see persistence of CIN, then you can decide about excision. But when endocervical margins are positive, you have to think of either re-excision or cone, or sometimes you may go ahead and do the hysterectomy. So that is the message I just wanted to convey. I think, yeah, this is again ASCCP guidelines, same thing they have mentioned. So I think before I give my take-home message, I think I expect the panel members to just give one word or one sentence take-home message. So we can start with Anjana Chauhan, madam, and yes, everybody can give one word, one sentence.
I just want to say, madam, first we should do screening for all the women. Any women walking in your OPD should be advised screening. And after screening, you should treat them. We should give them message that screening means not we are diagnosing cancer. We are doing screening to prevent cancer. So these things, this is my only message to everyone.
Okay. Yeah, I think, yeah, Dr. Bharati.
Yes, we must start screening with HPV, and awareness about HPV screening must be spread among gynecologists also.
Okay, good. Bhagya madam is not there. Doctor.
No, madam, I'm there.
Madam,
come back.
Ma'am, we missed you in the discussions.
Yeah. We missed your input. So at least madam, you give us message.
Your expert comments were missed, madam. Bhagya madam.
So much,
We miss you, madam. You're in the process.
No. Sorry, I have to go. So I came back again. So, Dr. Leela, my only thing I have to tell is that the screening and treatment is a long story. It's not a short story that we screen and then leave the patient alone. So I think the beginning of the screening only counseling should always be done, that she may need some kind of treatment. And I think hysterectomy, if you counsel them properly, actually you are going to prevent so many hysterectomies. Because we think that if there is something, they will go away. If I don't do the hysterectomy, she will go somewhere else and do the hysterectomy.
What happened?
It's a connection problem, I think.
Yeah, okay.
Your connection is lost.
Yeah, okay, yeah. Okay, madam. Yashodhara, madam.
Already so much good messages are there. I just want to say that yes, as far as HPV is concerned, join our training sessions. We are conducting. Dr. Gina knows it. And most important is that please don't do ablation of the lesion with the edges of lesion which you are not able to see. And you are it's a going injustice for the patient. If lesion is there, then it's so then you can see. If you lesion is seen, then do ablation. Else go for excisional process, take biopsy, and give proper management to the patient.
Okay. So Dr. Gina and Dr. Jyoti, I think you can give one sentence because we are running short of time probably. Yeah.
For CN cases, please do don't go for hysterectomy directly.
Okay,
Please
good.
do this lip excision or chondroplasty, and there's no role for direct hysterectomy for CA. Either we are doing over treatment or we are doing under treatment if we are going for directly hysterectomy in case of CA. So that is my
Dr. Jyoti, I think.
Ma'am, I just want to say that HPV positivity does not mean that the patient
Yes.
has cancer.
Yes.
So we should be very judicious in while we are doing colposcopy and doing biopsy and treatment.
Yes.
So this should be kept in mind. And this should be told to the patient also, because most of the time they come that no, it is positive, HPV is positive, I am going to have cancer, so please do some treatment. So this one should keep in mind. I think rest of the treatment we all know that how we have to treat.
Yeah, so anyway, we have discussed all these things. I have just summed up the take-home messages. I think it's very clear. We have, again, at each case, we have discussed what are the take-home messages. So thank you very much, my panel members, and Dr. Anju Soni Madam, Dr. Sweetie Soni, for giving us this opportunity. Thank you, my sincere thanks once again, and my panel members who have really done a wonderful job. And I hope I could convey some message to the panel, I mean, not to the panel members, to the participants.
Thank you, ma'am. It was wonderful.
Yes, thank you so much. I'm extremely sorry for not being there throughout.
No, madam.
Yeah, ma'am, your comments, please.
Yeah.
No. I'm sorry. That's my comment is I'm sorry that I could not be there throughout the panel. And one thing I think,
Leela ma'am.
Yeah.
I just have a very basic question. One of the participants has put in. When we are talking about screening general women, like as the patient walks in the OPD and we want to do some sort of cervical screening, are we okay with doing a conventional pap smear?
Yeah, we can do.
Or are you all sort of, I mean, I don't know, you people are more experts and see more patients. So are you all into liquid prep cytology, or you still are doing conventional cytology?
No, it basically depends upon the place where you work and the facilities what you have. So that is very, very important. So if you are working in an institute where you don't have LBC or HPV, you have to go ahead, still continue doing this conventional cytology only. There is nothing against conventional cytology. But wherever possible, now the WHO recommends that you should move towards HPV testing, because the sensitivity of the test as well as the true negativity of the test. What I mean to say is that it has got a high negative predictive value. So that's when they are suggesting. But if you don't have a facility, instead of doing nothing, you can still do conventional cytology. What do you say, Madam? Bhagya, Madam?
yeah, I think we cannot wait for the ideal thing to happen.
Yes.
So whatever is available, we should start doing.
Yes.
Can we stop sharing the screen, madam?
Yeah, please.
Yeah. So basically, what I would like to say that all of you have given beautiful insight into the whole complex scenario. But one thing which I would like to add here is that nowadays the generation doesn't want to believe in seeing the patient per se, putting in a speculum, which is so very important, which we call a VIA or whatever. That should be done by each